Hello from MD Briefcase and welcome to our podcast, Knowledge and Insight from Key Opinion Leaders in Medicine. Our independently produced podcasts are specially designed to support your practice. We hope you enjoy it.
Hello again. I'm Dr. Simon Carp, a general practitioner in Sydney at the Fountain Street practice, and I'm joined again today by neurologist Richard Stark, who works at the Alfred Hospital and Monash University in Melbourne and specialises in chronic migraine. He's here today to talk about an exciting new development in migraine management, which is the place of calcitonin gene-related peptide or CGRP inhibitors. Now, Richard, as I understand it, this is the first time that we have a class of migraine preventative therapy that's been specifically developed for this indication alone. So can you tell me a bit about, what these agents are and how they work?
CGRP is a very interesting chemical that has been recognised as being part of the migraine process probably for the last 15, 20 years. In fact, looking back even 30 years for people who are doing basic research. It's a peptide that appears in the brain. It also is seen in sensory nerves in the pericranial region. And there was evidence really from the fairly early days, 30 years ago, that CGRP levels do seem to go up in patients who have an acute migraine attack. The experiments that showed that were actually quite interesting. People were taking jugular venous blood of patients during migraine and found the CGRP levels were higher. Of course, it wasn't clear whether this was a causative thing or an epiphenomenon, but as time has gone by, it's become very clear that CGRP really does have a key role in migraine pathophysiology, and various medications that block the effect of CGRP have been demonstrated to be effective in treating migraine. Now, the medications that are coming through the system at the moment are in fact monoclonal antibodies blocking either CGRP itself or its receptor. And these have proven to be highly effective in preventing migraine in many patients.
Well, what is the role of CGRP in normal life and in migraines in particular?
So in normal life, CGRP is very widespread throughout the body. It plays a part in aiding vessels to dilate, and it's seen in the gut, it's seen in blood vessels. Having said that, blocking it seems to produce remarkably little in the way of side effects outside the nervous system. And it is, I guess, one of the great paradoxes that we see, that we're blocking this chemical, which is so widely distributed, seems to have very little in the way of side effect profile. In the nervous system and in the causation of migraine, migraine's obviously a very complicated pathophysiology. But one of the key things to it seems to be that CGRP and other chemicals extruded from sensory nerves near blood vessels will produce a sterile inflammatory response around blood vessels. So that's why patients with migraine actually have this sort of throbbing vascular type of pain. It's not that the problem is actually intrinsically within the blood vessels, but there's this inflammatory response around them created by these peptides. And
so it's not necessarily the kind of, I think when I was a lad, they talked about the vasospastic and then the vasodilation phase of migraines. And this sounds, but in a sense, perhaps it's more the inflammatory response rather than the vasodilation itself that causes the pain.
That's absolutely right. And, for a long time, people were looking to deal with migraine by doing things specifically to alter the caliber of blood vessels. And some of those medications did have some effect, but mostly they did not. And it really turns out that the things that have the greatest impact, so the triptans, which agonists for 5-HT1B and 1D receptors, and the CGRP blockers, both have this impact of reducing the amount of inflammatory peptides that are released around blood vessels and reducing this sort of inflammatory response.
So what sort of impact do they have when used as a preventer? What is their kind of therapeutic efficacy?
So we now have a fair bit of information about this class of medication, and they can be highly effective. There are 4 different monoclonal antibodies that have been trialled, and all 4 are highly effective in reducing migraine frequency and severity, both in episodic migraine and in chronic migraine. That doesn't mean that they work for everyone, but they do work for a large percentage of patients, and they certainly produce a dramatic reduction in migraine in a proportion of patients who've not been able to benefit from other medications.
I mean, just in terms of reduction in, migraine, are we looking at a 50% reduction in headache days per month? Are we looking at more than that, less than that? What do we mean by, a successful impact here?
So, I mean, 50% reduction is usually what is regarded as an indicator of a successful response. These drugs certainly produce a 50% reduction in a substantial proportion of patients. Not everyone, but in a significant proportion. Probably different from other medications, may produce a 75% reduction or even 100% reduction in headache in some patients.
So as with most drugs, there's a bit of a spectrum of response. Some people do really well, a lot of people do fairly well, some people unfortunately don't. So yes.
Exactly.
I mean, you mentioned before, that this is a widespread peptide in the body and is found in a lot of organs. But I think, as you said before, there don't seem to be a lot of other side effects from blocking it, but presumably there are some. Can you tell us about any adverse effects people might experience?
Probably the most common thing that we come across is constipation. And it does seem to be that it's an important chemical in the gut. Having said that, if you look at the trial data, the number of patients reporting constipation during the major pivotal trials was quite small. But in real life practice, I think the number of patients is not tiny. The majority of patients don't have this problem, but there is certainly a small number of patients where it can be moderately troublesome.
I mean, I guess as well as sort of frequent side effects, we're always interested in the rare but serious adverse event. Has anything showed up like that in post-marketing trials?
There really don't seem to be any major concerns at this stage. I mean, there are anecdotal reports of individual cases of this or that, but whether this is anything more than chance is not clear. I mean, these medications are new in Australia. We've probably had experience of them for now a couple of years in relatively small numbers of patients, but they are certainly more widely used in the States. The trials were started there sometime earlier, and they've been marketed now in the States to large numbers of patients. So we are starting to see reasonably large post-marketing cohorts without any major adverse event profile coming through.
Are there any contraindications to their use that GPs should be aware of?
There aren't really any major contraindications. Obviously, someone who's had an allergic response to one of them would not be given it again. But in terms of pre-existing contraindications, pregnancy, as for all new medications, their safety is not established, and likewise for breastfeeding. So we really don't know whether they're going to be safe in those circumstances, and one would not be keen to use them in that situation. But otherwise, the main current restrictions, I guess, relate to availability and price.
Peptide molecule. I think these are peptides or antibodies. Presumably they can't be taken orally. How are they administered?
Yeah, so they're given by a subcutaneous injection for the 3 agents that are available in Australia. All three are available as a monthly subcutaneous injection. One of these agents, we have some evidence from the trials that it is possible to give it on a once every 3 month basis, but the usual thing for all three is for them to be given on a monthly basis.
And do you find that patients can be trained to inject these things themselves, presumably? Do they come with auto-injectors?
Look, they vary between the different agents, but certainly those with an auto-injector, patients find very easy to use. And certainly I've had patients that come to me and say, look, I don't think I could inject myself, but when you show them what to do and they do it, they're able to do it without a problem. So I think, that self-administration is not a big deal. And of course, it is one of the great advantages of these agents that, once they're in, they're in. And so compliance with taking a tablet every day is not an issue with the medications.
So it sounds like adherence and acceptability you've had pretty positive experience there, that people, take them on and then stick with them?
Correct. Patients have been very happy to do that, and certainly when patients get a very good response to them, they're delighted and they're very happy to continue on.
So what do you see as their place in therapy? What's the sort of patient where you'll be thinking about initiating one of these CGRP inhibitors?
So it would normally be a patient in whom one was going to be using a preventive medication, and probably someone in whom one of the standard oral medications has not been effective. Almost certainly the algorithm will be that patients should be tried on simpler and cheaper medications first, but there is certainly no doubt that these medications work for many patients much better than the oral medications do. So I think a patient who's not had a satisfactory response to oral medications should be considered, particularly when having high frequency migraine. It's likely that they'll be made available first for chronic migraine, patients with more than 15 headache days a month, but certainly for patients with high frequency episodic migraine, say 7 to 15 headache days a month, they work very well, and many of those patients would think them very worthwhile as well.
How do they sit alongside, I guess, the other sort of injectable therapy for migraines? I mean, in terms of deciding whether someone should try Botox or they should try a CGRP inhibitor, is there a particular patient that would benefit from either, or how do you decide which treatment would be useful there?
So I think it's very difficult to know whether a patient's going to respond better to one or to the other. They probably work generally in the same system, but have slightly different modes of action. So it's not surprising that there are patients that respond better to one than to the other. What tends, to qualify for Botox, a patient needs to be having more than 15 headache days per month. So a patient with high frequency episodic migraine would not be able to access Botox on the PBS system. So that would be one factor at present. The Botox is administered once every 3 months, but it has to be administered by the treating neurologist. So it does have the disadvantage for patients who are situated far from a neurologist, so people in rural and regional areas have a lot of travelling to do. So I have patients who come to see me from Mildura. I have patients that fly from Tasmania when COVID's not about to have Botox injections, but the capacity for them to self-inject would obviously be a great advantage. So I think there will be people who you couldn't predict whether they're going to be better with Botox or better with CGRP inhibitors, but you might choose one for practical reasons. At present, the main practical advantage of Botox, of course, is that it is funded on the PBS and so is somewhat less expensive for patients.
So these CGRP inhibitors are not yet on the PBS. I mean, how do people go with affording these medications?
So that's correct. There currently is there are applications before the PBAC, and at present there is not an agreement to fund them. So we are hoping that there will be progress made in that regard. But at present, patients need to self-fund these medications, and obviously that's a difficulty for them.
Is there any particular monitoring that's required for these medications?
At the moment, there's no required monitoring. We think because they're new medications, it's obviously a good idea for patients to be under some type of review, but at the moment there's no entrenched monitoring protocol.
Thank you very much, Richard, for what's really been a very informative discussion on a topic I think that's quite new to a lot of GPs, and giving us a really great enhanced understanding of how these new CGRP inhibitors are going to work for our patients with migraine. Thank you very much.
It's a pleasure. Yes, it's an exciting time in migraine.
Thank you for listening to the MD Briefcase podcast. If you'd like to explore our full range of podcasts, videos and accredited programs, please visit mdbriefcase.com.au.